Thank you, Mr. Chairman. I apologize for being late. We had a natural resources meeting as well, so I sent your regards to that meeting. I know you couldn't be there because of here. I'd like to thank our panel for being here. Incredibly important issue, particularly for districts like mine, rural Colorado, 54,000 square miles. And as I've traveled through those 54,000 square miles, just held a town hall meeting with senior citizens in Pueblo, Colorado last week. They're worried about the President's health care mandate and how it's going to be able to impact them. I've talked to senior citizens in Del Norte, Monte Vista, Alamosa, Cortez, Crawford, Hotchkiss, Egner, some towns a lot of people haven't even heard of. They can't find a doctor that is willing to take Medicare. So I guess, Mr. Smith, I'd like to be able to start with you. With the number of small businesses, and a lot of our doctors are small business people, solo practices, what effects will the President's health care mandate have on rural Americans, rural citizens' access to health care from your perception?
From my perception, the impact I look at first is of the patient. As you mentioned, it's very difficult as a patient, a new patient to physician practice, to be seen if you have Medicare, especially if you have Medicare without any kind of gap insurance. A physician has to limit the amount of Medicare that they see in their practice to be financially viable. If you have a pure Medicare practice, it's not viable. The reimbursements are too low to be able to do that. Most physicians that I work with, we conduct about 3,000 searches a year across the country, so we have an excellent resource of information. Will tell me that Medicare rates generally put them at a break-even. That's their cost of doing business. So you've got to keep that to a third of your practice. And some specialties, such as internal medicine, you might get it to half, but you cannot have that happen. You see physicians, as they get older, their patients get older, they have more and more Medicare, and you can look at their financials, and they slowly dwindle until such a day that the decision is, I'm working for free, I've got to get out of practice. So now as we look at this, we have patients that could come under the system at was going to be a Medicaid rate, and we're elevating them to Medicare, thinking that's going to be a driver for physicians to see them. One, that's a temporary raise. Two, it's not attractive. And those physicians, those patients, the 30 million people we're adding to the system, will have a card that gives them insurance or a version thereof. What they will not have is access. The second piece of that is supply and demand. The legislation does address some areas of need of attracting people to the system. There's a shifting of unfilled primary care spots that really is resulting in a few hundred physicians. But the issue is we can add as many people as we want to the medical schools, but we haven't added a single dollar as it comes to the residency program. And so all you'll be doing is shifting foreign physicians out of the system and replacing them with American-trained physicians. But at the end of the day, it's the same number of physicians coming out of the machine. And the places like Brush and Trinidad and Sterling will still not be able to find a doctor because there'll be more attractive options in the larger cities.
Good. If we could, Mr. Smith, I'd like to explore that a little bit because you were focusing a little bit on the economic end of it from the doctor's perspective that's sitting there. Majority of doctors I know actually went into healthcare because they truly care about people. They're going to limit the number of patients that they can see simply because they want to be able to provide quality health care. If you're trying to run them through like an assembly line, is that going to reduce the quality of health care?
Well, there's no doubt. I mean, the physician-patient relationship is the most critical thing that we can talk about, and our three colleagues here, I'm sure, would completely agree with that. But your only choice is to do more. And I would bet that each of these physicians here see a few more patients each year to be able to make their practice viable. Not so much as to just financial reward, but just to make it a viable business. They have employees, people to count on, and your own income is it. But the patient will be left on the sideline.
You just mentioned doctor-patient relationship, that we shouldn't be getting between that, that if there's going to be a medical decision that is to be made, let's have the family, the patient, the doctor do that in the doctor's office. Do you have some concern about the IPAB board?
Well, yes, to answer your question. We've seen this in other countries, and we've seen some of the impact that it's had. I saw recently in Europe where epidural injections were taken off the list of care that will be provided, other decisions that are being made. But each of these decisions that you've seen along the way, the majority of these decisions are made without physicians involved. We speak to thousands of physicians on a monthly basis, and I've yet to find any of the ones that had the lab coat and were on the front lawn during these conversations. But anything we can do, it has to come down to this physician-patient relationship.
Dr. Yassett, saw your head nodding. Would you like to make a comment on that?
I would agree, and the American Osteopathic Association adamantly opposes the IPAB. We think that's just wrong-headed, if for no other way to say it. You know, the other thing that is concerning to me in regards to Medicare, as Mr. Smith said, you know, you're almost getting to a point where you're just barely breaking even as far as reimbursement is concerned. Mm-hmm. What happens in the next 10 years when they cut $500 billion out of Medicare because of ACA? Does anybody know? I mean, obviously reimbursement's going to take a hit. It has to take a hit. I don't see how else you're going to reach that number.
Excellent point. Dr. McKentry, maybe you'd like to jump in a little bit on this, because I think Mr. Smith said it just very well. We can insure everyone in the country, but there's a quantitative difference between insurance and health care, two completely different things. And if we're wanting to be able to get health care, are you seeing a real problem with the President's health care mandate when it gets down to actual delivery of health care? And I'm speaking primarily for rural America, rural Colorado. I know some of our metropolitan areas have an abundance of doctors and specialties, but let's talk about rural America.
I don't know that the mandate in itself creates an access issue. I think the access issue is really driven more by reimbursement levels. So if your reimbursement level falls below the level of your ability to deliver the care. But
the reimbursement level is actually via the mandate. That's part of the program.
Well, right? My understanding of the ACA is that it does cut $500 billion out of Medicare.
$575 billion.
Over 10 years, and does fail to correct the SGR, which is another $300 billion. So I think that's the access issue there. I think I certainly have an issue, a philosophical, constitutional issue with the mandate for myself personally. But perhaps I'm not sophisticated enough to realize how it will impact access, other than the issues we spoke to of, well, it is possible to provide someone with insurance, but if that insurance doesn't pay costs, then you're basically uninsured. For example, if you put people on Medicaid, I think it's something like 40% of all physicians won't accept a Medicaid patient because the reimbursement is so low. And I believe my understanding of the ACA is that by 2019, Medicare rates will be around where Medicaid reimbursement rates are now. So I think that is a huge issue and a potentially devastating one for access to care for Medicare patients going forward.
So effectively, our senior citizens, people who have run the race, are walking in the door with their Medicaid card, putting it on the table, it's insurance, and they aren't able to get a doctor.
I think you could definitely see that problem.
That is a real challenge. Mr. Smith?
I would add to it, one of the things that my firm does is we do studies on wait times. How long does it take to get to see a physician? And an unintended outcome that we discovered was the greatest increase in wait times of any metropolitan market was Boston. And the difference between what occurred between our first wait time survey and our second was the implementation of universal health care. So a place that I think any of our colleagues would argue have the most physicians, the most training programs, the environment you would not expect to have that issue are having that issue. So if that's happening in Boston, what's going to happen with your rural constituents? I don't think that's a difficult question to ask.
Right. Dr. McKentry, maybe, or any of you if you'd like to, we've got to be able to address some of the accessibility. Every American, I think that we can all agree, we want affordability and accessibility. The President's health care mandate fails on both counts. What can we do? What should be done to be able to increase the number of physicians that are going to be able to get into some of these rural areas, to be able to provide that access to health care?
In answering a similar question before, I thought perhaps injecting a market solution to this problem would go a long way to improving quality, decreasing costs, and improving access. I think if patients have some skin in the game, then they are more likely to seek health care that is of quality to them. If somebody else is paying for their health care, especially if it's first dollar coverage, they're less likely to become shoppers. They're less likely to search for quality. They're much more likely to search for volume. So I think in the current situation, we have a volume-driven process that's going to be exacerbated by the health care law instead of one where we'll be looking for quality. the healthcare law does attempt to impose quality on the system through comparative effectiveness research and on other things, but that's it's sort of a top-down approach.
You know, ultimately, and I just kind of like to get your thoughts on this, original CBO estimates on the President's health care mandate stated that it was going to cost $900 billion. And in the White House, there was dancing in the hallways over that number. I'm a small business guy. $900 billion is a lot of money. CBO just rescored this. It's going to be $1,787 billion with administrative costs. We're going over $2 trillion. Is there a better way to be able to spend $2 trillion?
Congressman, I'd like to just comment a little bit on before and then this question as well, and that is that if we're going to increase access, we have to be able to pay for it. And so that's a concern. We have to appropriately pay physicians for the services they perform. So if we're going to reduce costs within the system, I think if you get any large number of physicians in a room and talk about how we're going to reduce cost, that you will come to the issue of utilization. And so the American College of Cardiology for years has been working on appropriate use criteria and our registries. And I think that we, as a profession, are going to have to look at appropriate utilization and cut out the utilization that's inappropriate, and that could save, possibly as much as a third of what we're spending right now on health care.
Mm-hmm. Would tort reform be a good idea?
Absolutely, and I was going to just mention that. The patient comes in with back pain, let's say, and you may send them and get x-rays of their back, let's say low back pain. They come back and they say, well, doc, you gave me some medicine, it really didn't help, I still got the back pain, and the next thing you know, you're ordering an MRI. Mm-hmm. And why do you do that? Is it because it's really a necessary test, or is it because you're worried about the liability of the situation? If am I missing something? Or is there something else going on here that I'll pick up with the MRI? And you're thinking about the legality of the situation more than you are, is this really appropriate care for the patient? And I think that's, medical liability is what's perceived a lot of times. And I think that's really true in the ER setting. And you wonder how much money spent needlessly in the emergency room on CTs of the head, stress tests for chest pain, all those kinds of things where they may not necessarily be needed.
Well, you may have been a little like me. Thought it was curious that the administration and the 111th Congress, we're in the 112th, wouldn't even consider tort reform, because I've actually held meetings with physicians. Just met with about 24 physicians over in Glenwood, Colorado. Tort reform came up as one of the #1 cost drivers, and it's the fear factor that if a patient isn't totally forthcoming and you didn't catch it, you can be sued. We've got to be able to bring some common sense into that portion of the equation as well. So certainly thank our panel for taking the time to be able to be here. and we'd love to be able to hear more from you. This is about affordability. It is about accessibility. And as I travel through rural Colorado in my district, I'm talking to senior citizens right now who are frightened about what the consequences are going to be to their health care going forward as we continue to see the President's health care mandate put into place. And I think maybe we should have started with you at the very beginning. Talk to the physicians before they started writing a 2,000-plus page bill that many of them didn't read yet passed. And Minority Leader Pelosi was correct. She said, we'll find out what's in it once it's passed. Unfortunately, that discovery is still continuing. We're seeing increased cost, increased control, and reduced access to health care in this country. Thank you for coming in today. I yield back, Mr. Chairman.